Well, good morning, everybody. I've got 11:01 on my computer, so I'm going to go ahead and get us started. Welcome to this CHCF webinar on improving prior authorization processes here in California. My name is Christoph Stremikis. I'm the Director of Market Analysis and Insight here at CHCF. I am really pleased to be with all of you here today and host this conversation this morning with two national experts that have recently completed some fairly in-depth work with a broad group of consumer advocates, behavioral health experts, and industry leaders across our state. I'm going to introduce both of them in just a second and have them talk about their findings and some recent federal and state level developments in this area. But before I do that, just a quick note on the agenda and logistics. We're going to spend about the first 30 minutes or so of our time together hearing from our experts and their work. Our audience during that time is going to be on mute. You'll be on mute throughout the webinar. But please do provide any questions that come to you in the Q&A box in Zoom that's on your screen. Give any questions that come to you at any time, just please put those in that box. And we will get to just as many as we can in the second half of our webinar. Today's session is being recorded. That recording, along with additional event material, including a very long, detailed and informative report that Wendy and Lauren have put together, is available on our website at chcf.org. Someone always asks, and so yes, the slides will also be available for download on our website in the next couple of days. Finally, just on logistics, I'll nudge you all on this at the end. But please, we do ask you, once the webinar is does complete, an evaluation form is going to pop up on your screen. I promise you that we really do read all of your feedback very closely, and it's used to help guide future programming. And so thank you for just taking 30 seconds or a minute at the end of the webinar to provide that feedback. Okay, so let's get to the content. As I think everyone knows, health plan practices have been at the forefront of many national conversations recently. Today, we're talking about one very specific utilization management practice called prior authorization, or PA. And I think most folks on this call have a general understanding of PA as an important utilization management tool that health plans and medical groups use for the very worthy goals of ensuring patients receive the right care, that care is covered by their plan, and that care is delivered by a contracted provider. Now, despite these important goals, there is also a fairly widespread consensus, including here in California, that the processes by which prior authorization are carried out often warrant significant improvement. At best, the inefficient and opaque nature by which they are sometimes carried out can lead to significant frustration, wasted time, and delays that have negative impacts on both patients and providers. And at worst, the ways in which these practices can sometimes be carried out do cause real harm and suffering to patients and their families. These are very complicated and important issues. And fortunately, we're joined today by two experts that can help us understand a little bit more about some of the reform opportunities and what different approaches are. I'm super pleased to introduce our first speaker, Wendy Waring, who is the current president and CEO of a national nonprofit organization called NEHI, which stands for the Network for Excellence in Health Innovation. I'm not going to read Wendy's very impressive bio, but just know she's held positions at HHS. She's been a state Medicaid director. She's worked within industry and led multi-stakeholder work specifically focused on improving prior authorization processes using state regulatory and other voluntary industry-driven levers. Wendy, I'd invite you to turn your camera on, unmute yourself, and then once you've done that, talk to us a little bit more about some of the recent multi-stakeholder work that you just completed out here in California.
Thanks. And Lauren, my colleague, will be running the slides, so I'm going to be saying next slide. I think we'll head, because of Christoph's terrific introduction, right to this slide. Great, Lauren, thank you. And it's a pleasure to be here. This is an incredibly important topic. And as Christoph emphasized, the purpose of our project was really to better understand the individual issues that stakeholders in California prioritize, and then to match possible reforms to addressing those issues. As you all know, there is a lot of activity both at the state and federal level in proposing ways in which to change prior authorization processes, to improve it, to reduce the cost to patients, to providers, as well as to health plans. And often these reforms are complex to implement, and they can get delayed by varying forms of opposition. So our approach was really in this project to hear from different views and to come together to find out how could we advance at least some reforms that improved prior authorization for those stakeholders involved. I'm not going to go through the burdens and the benefits of prior authorization. Everyone here undoubtedly knows those, except to acknowledge that there is an increasing view that, in fact, the burdens are beginning to outweigh the benefits and the legitimate goals of prior authorization, a form of utilization management. Next slide. So here are some of the issues that we flagged in conversations, and you heard who was involved. We had an incredible group of people very engaged. A very simple issue right at the forefront is the lack of information right at the point of care of whether or not prior authorization is required. As you probably know, this causes providers to submit unnecessary prior authorization requests, which can delay care and actually also burden health plans who have to deal with those prior authorization requests when they are not required, thereby burdening patients, burdening providers, and increasing costs. A second is that standard outcome measures are not available for assessing the impact of prior authorization. In California, the legislature actually asked the California Health Benefits Review Program to do a report on the state of prior authorization in California. I think this was now 2 years ago. And the Benefits Review Program had to do its own individual voluntary survey on prior authorization. But at the end, it concluded that its findings on the gaps that its findings were limited by significant gaps in available data. Data is collected by some, but not publicly available. And further, data is not analyzed and so is not meaningful. Third, repeat prior authorizations and concurrent reviews during a course of treatment continue to come up as a major issue. Some of chronic care is highly protocolized, and yet there are repeat prior authorizations that interfere with the patient's care and can expose a patient to financial liability. A fourth issue, which is really related to the second one, which is that the lack of standard outcome measures, is that prior authorization requirements are not well understood, and therefore there is a perception of mistrust and that there are too many prior authorization requests and an inability to really judge whether the benefits of prior authorization are being achieved. And last but not least, prior authorization will likely continue to be required for very complex care, where there may be more experimental treatments, more options, newer options to treat very complex care. And yet the judgments made at the health plan level by professionals often don't match the expertise of the prescribing provider. So that was a further issue. Next slide. So certain reforms really emerged as priorities. Numbers 1 and 3, automation and extending the duration and scope of prior authorizations, really address the process by which prior authorization is administered. Numbers 2 and 4 there on your screen really get at whether prior authorization is required and its benefits and its impact. And we're going to talk about each of these reforms in much greater detail in half of this webinar, really to solicit their feasibility as to the way in which they match the issues that many of you are experiencing. Next slide. I have a note that my internet. So I'm sure many of you know that there are significant tailwinds on the reform of prior authorization. In January of 2024, CMS finalized a rule that had been pending for, I think, 2 years, focused on 2 issues. One, automating prior authorization through the use of standardized FHIR data and the use of application programming interfaces or APIs. And second, addressing the timing by which prior authorization decisions are made, including reporting on certain prior authorization metrics that would enable folks to understand whether, in fact, where the issues were. We're going to describe automation in greater detail shortly, but automation is often confused with artificial intelligence. Artificial intelligence can be part of an automated process, but the automation of end-to-end prior authorization really takes people out of the prior authorization process by allowing payers to pull information from electronic records. It first immediately notifies a provider whether or not a prior authorization is required, then allows payers to pull information automatically and match that information to the rules, thereby dramatically accelerating the speed of a decision. Congress has also proposed bipartisan legislation in the Seniors Act, and that will address some of the concerns about AI, but also expand CMS's authority to continue to address automation of prior authorization. Next slide. So states are similarly pursuing reforms along these lines. Most of what the states are doing, and there is great variability, but you can see we've classified our proposed reforms and the number of states that are pursuing those reforms. Washington State, I think Lauren will mention it, is actually moving forward with automation and has a hearing today on the implementation of automation in the state. Because the federal rule, I neglected to mention, although can only govern a portion of the health plans and providers. It applies only, the federal rule applies only to a certain portion of public payers, Medicare Advantage, Medicaid, Medicaid managed care, and CHIP. It does not apply to Medicare fee-for-service and then does not cover commercial payers. So when a state comes forward, the Washington State and Virginia, which is pending, is trying to extend and scale automation across the payer landscape and thereby enable providers to access automation benefits. Refining public reporting requirements is part of what states are pursuing, extending the duration and scope of prior authorization approvals. Many states have recognized this, and then developing transparent principles for annual review of prior authorization is a suggestion that really came out of our gathering, our project, and we'll discuss that in greater detail in a moment. Yet California could be the first state to pursue that. Next slide. and I know my time is up. So many of you know that California has in fact targeted prior authorization reforms in several areas. There was an effort to pursue automation. It failed. Lauren will talk about that in greater detail. And likewise, one of the more sort of popular reforms, but a problematic one, is gold carding. That gold carding legislation also failed, and we'll explain gold carding to those of you who are not familiar with it.
Thank you so much, Wendy. There's a lot there that I'm really excited to jump into in the Q&A with you. And we'll have some time. And just as a reminder to folks that are joining us, please do put any questions that you have for Wendy or Lauren. We'll get started in just a second here into the Q&A box, and we'll get to just as many as we can at the end. Wendy, one thing I did want to ask you before we transition on to Lauren is just some of this idea about the role for states and state policymakers, given what seems to be a lot of action at the federal level. And so can you just put a fine point on that? Like, why are states stepping up? Like, is what the federal government doing? Are those, like, where are the gaps? Can you just kind of reinforce that point for us?
Yeah, so that's a great, thank you for that question. It's not so much the gaps as the limits of federal authority. So the federal government can't mandate reforms in all sectors of the healthcare industry. And so there is a gap in its scope of reform. I think, I neglected to mention, I think the federal government has taken an appropriate lead, and there are many arguments that the federal government should actually lean in further. You'll see on the, I mentioned this earlier, on CMS's website as of yesterday, they have proposed a rule to really dig into reporting at a disaggregated level what is going on in utilization management, and particularly in prior authorization by item, service, and drug.
Super helpful and lots to dig in there. And I know this is an issue that I will just kind of re-emphasize. The report that you put together, I know just does touch on this, sort of the limits of federal authority and the role for states. And so lots more to talk about there, lots more to read about if folks are interested in that report. Again, it's available on our website. But in the interest of time, I do want to move us on. So thank you, Wendy. We'll bring you back in just a second. I do want to bring in our next speaker, though, Lauren Beadle. I won't give you Lauren's entire bio, which is quite impressive, but I would note that in addition to her national expertise and experience in prior authorization processes, she's actually spent a little bit of time down in Southern California at Harbor UCLA Medical Center and completed her MPH at UCLA. So Lauren, it's always great to have a Bruin with us. Welcome back. We'll claim you for that. I see you got your camera on, you got yourself unmuted. Can you tell us a little bit more, maybe go into some of the rationale for the recommendations as well as some of the other context for national and state-led reforms?
Definitely. Thank you, Christoph. Yeah, I'd love to dive into automation. Before I talk more about the rationale for California to consider a mandate to extend automation to apply to state-regulated payers, I just want to share our definition of what we mean when we talk about automating the prior authorization process. I know Wendy mentioned it's often an umbrella term and AI gets lumped into that. But at the core of it, we're talking about adopting, an end-to-end prior authorization request. So everything from the initiation of the request, is it required, all the way through to the payer or the intermediary, such as a clearinghouse, all the way through to their decision. And this should be adopted electronically and use a defined set of data exchange standards. Those standards should be used by an entire community so as to enjoy the benefits of automation, because that standardizes the process. And the process should really have little to no need for human intervention. So if we look at this pretty basic step-by-step automation workflow, once a provider decides on a particular service or treatment for a specific patient, they can then launch an inquiry through their EMR to understand, is prior auth required or not? So in that instance, they're going to get a yes, a no, or we need a little more information to say yes or no. Assuming they need more information or assuming that a prior authorization is required, the provider will move on to the next step. And that is when the information needed to satisfy the request will be pulled automatically from the provider's EMR by the payer's system. And that's going to be used to auto-populate the payer's questionnaire, their documentation, whatever they need to satisfy that request. In the next step, once all of that information is compiled into what we call a prior authorization bundle, that is sent electronically to the payer or the intermediary, and the provider and their staff or whoever is submitting the request, they have the opportunity to review that before that goes to the payer, but that's a workflow preference. In the next step, so once the bundle is sent to the payer, the intermediary, they're going to process that decision. And in the majority of cases, they can process that in real time and send the decision back to the provider's EMR. And so this is really going to, one, serve to reduce delays in patient care, but also going to reduce the need for phone calls and faxes between payers and providers to, ultimately process that request. And then there will be some instances, maybe some more complex requests for treatment or services where the payer needs a little more information. So if that's the case, they will prompt the provider or their staff back to the point in the workflow in which they can capture the information that's needed. So now that we all can kind of picture the automation workflow, the stakeholders that we engaged in this project were fans of automation for a couple reasons. One, this was going to address that issue of a lack of information at the point of care. This is a really excellent way to reduce the submission of unnecessary prior authorizations. They were also fans of extending the CMS final rule that requires the use of FHIR APIs to apply to state-regulated payers. So that's going to do a couple things. I think I mentioned before that's going to standardize the prior authorization process because we've got a larger community of payers and providers who are using a defined set of data exchange standards, those FHIR APIs. And this is also going to standardize the implementation process. So a mandate is going to provide an opportunity for California to develop a statewide technical implementation framework or roadmap, whatever you want to call it. And that is going to provide guidance to payers and providers on where to start the implementation process. We would recommend following the Da Vinci implementation guides, and I don't want to get too technical. The implementation guides are recommended in the final rule. These are the coverage requirements discovery, is prior auth required or not, documentation templates and rules, what documentation do we need to satisfy the request, and then PAS, prior authorization support, and that's that exchange of the prior authorization bundle and the decision back. So we would recommend starting with CRD because that is really going to alleviate that burden again around whether or not prior authorization is required. This technical implementation framework can also instruct folks on when to start that implementation so that they are ready to go by January 1st, 2027, along with the impacted payers and the CMS final rule. And then the Da Vinci implementation guides are also friendly to modifications. And I can give some more examples on what those modifications are as we get further into our discussion. But essentially, those can really address, stakeholder concerns and workflow preferences for payers and providers. So in addition to standardization, a statewide mandate is also really going to foster collaboration. Automation is something that, everyone needs to put their weight behind and buy into it in order to achieve maximum benefits. And this is also an opportunity for those payers and providers who are maybe able to start implementing before others to share some of their successes and challenges with folks who have not yet started implementation so that when they do, they have a little more of a leg up and they can play catch up. So that's automation. We will also say automation is really, it's not going to solve all the issues related to prior authorization or all the issues that were flagged in this project. And that is where data can come in. So Wendy mentioned, and Chaburp has found that there's a pretty severe lack of publicly available data on the prior authorization process. And so, stakeholders were also a fan of a mandate that would also extend the provision of the CMS rule that would require data reporting requirements on prior authorization so that this can tell us, is the prior auth process working? How well is it working? Where can we focus our energy around future reform efforts? And which kinds of reforms could be successful in those areas? So, California would also have an opportunity to make some modifications, kind of like on the automation front, and really consider, get multi-stakeholder groups together, consider whether there are other reporting requirements that would provide more insight into some of the issues that stakeholders have flagged. And we listed a couple on the slide. Again, I can talk more about those as we get into the discussion, but these were some of the issues that came up during our project. So we really recommend pursuing automation and public data reporting requirements in parallel. I noted that data will really, flag and provide highlight other areas of the prior authorization process that maybe aren't working as well as it could. And then automation is also going to really help to reduce reporting burden. And we can get into that as later as well. This recommendation on extending the duration of an approval was really more of an umbrella recommendation. So we'd recommend that California consider extending authorizations in a couple different areas. One would be extending the period for which an authorization is effective for well-defined courses of treatment. This could be specific kinds of chronic care, maybe generic medications in which the dosage and administration is unlikely to change. This is really working to reduce the number of prior authorizations for care that is planned, agreed upon. It's respected by medical societies, really unlikely to change. We'd also recommend extending that period during an insurance transition, extending an authorization to reduce the potential for delays in care. We know Medi-Cal already does this for fee-for-service members transitioning to a managed care plan, and several other states have done this as well. Extending that authorization for a 30-day period all the way up to a 90-day period. And then finally, we'd also recommend there could be some areas in which extending approval for a group of codes or a family of codes, as we sometimes call them, could be appropriate. We've talked about surgical instances, imaging, radiology. Sometimes a servicing provider has approval for a certain code. They get in to do what they need to do, and they find they need to do something a little bit different. Which would be a separate code, and they would need a separate approval. But if they had approval for a larger group of codes, that would reduce the need to go in and get another approval. Then finally, I know Wendy mentioned, we haven't seen other states, pursuing this idea. That's not to say that they aren't, but we thought it would be really interesting and worthwhile to have payers share their principles or criteria on which they make their decisions to add or remove requirements, excuse me, from their prior authorization list. So we've heard from payers, they already review their prior authorization requirement lists at least annually. So ideally, this would be a light lift, just share the criteria on which they're making those decisions. They would still maintain their autonomy on the criteria they use, but this would ideally provide more trust and transparency into the process as to why some payers are just slashing their requirements on the one hand, and then maybe adding some requirements to some other services that had not in the past been subject to prior authorization. And on a really optimistic level, maybe this could increase some standardization in the criteria that are used. There may be payers who decide that there are requirements or criteria or principles used by other payers that may work well for them. So, all in all, and I know I moved through these pretty quickly, our recommendations were really designed to streamline the process and remove waste where we can, while also increasing trust and transparency, because it is a necessary process. And that is something that, all of the participants we engaged with throughout this project agreed.
Thank you for that, Lauren. That's a lot. You covered a lot of ground really quickly there, and I'm really looking forward to digging in to that a little bit. And we've got a lot of great questions that have come in while you were speaking. So we do want to transition, use our last 20 or 30 minutes here for a general Q&A that I'll moderate. And so I'd invite Wendy to unmute herself and flip her video back on and kind of invite her back into this conversation. And I would invite our audience to keep those questions coming. Any questions that you have for our panelists, please do put those into the Q&A box, and we'll try to get to just as many as we can. I do want to dig in specifically to these, maybe some of the considerations or the complexities around two of these recommendations that emanated out of this work around automation and data. But before we get there, I just want to circle back to two things. One is, Wendy, you alluded to something, and either Wendy or Lauren, I think you could handle this question. You alluded to something called gold carding, which, and I think it's was something that you mentioned had some drawbacks, and that may be the case. Can you just remind folks what is gold carding? And then just as, kind of as balanced as you can, sort of just the facts. Has this been implemented in other states before? And what are some of the strengths and weaknesses of this approach? Either one
So
of you have?
I'll start, Lauren will leap in. There are 7 states now that have implemented gold carding programs. Now, we don't have, really great evaluations of those programs, but to say what they are, they're performance-based. So in some cases, as in the California proposal, they would require elimination of prior authorization for a service that had a very high, like a 95% approval rate. In other cases, gold carding is implemented on a physician or physician group level so that the health plan eliminates prior authorization or waives prior authorization for physicians that have consistently had their request for prior authorization approved for a certain service or item. Gold carding is problematic in that it is very difficult to administer. We do know that in Texas, I think it's something like less than 5% of physicians have received waivers pursuant to the law. Lauren will correct me if I got that wrong. In part because the standards for obtaining a waiver are unclear and then can be variable. Different plans can have different standards. So physicians can be very confused about whether they are waived for prior authorization for one plan versus another. We think it is not a fruitful reform effort because of that variability and because the number of prior authorizations that are used to determine whether the approval rate is appropriate varies and is difficult. So you can have a very high approval rate for a very small number of prior authorization requests, which wouldn't be indicative that a service is being used appropriately.
Very helpful. Just in the interest of time, Lauren, unless you've got anything burning, I am going to move us on. So we have quite a few questions.
Sorry.
That was perfect, Wendy. Thank you. I do then want to spend most of our time talking about 2 of those high priority issues, both automation and data. The automation conversation, there's a lot of pretty technical questions that we'll get to in just a second, but I want to start with more of a high level question back on the data and the reporting. We have a question that came in from the audience around some of the standard outcome measures for PA processes. Wendy or Lauren, can you remind us, like, what data actually is available now? Like, if someone wanted to go and understand a little bit more about how often this is being used, what some of the outcomes are. You mentioned the CHBRP analysis and that survey. Can you speak a little bit more about that? And are there other data sources now? And what's coming in with the new federal rule? Kind of level set a little more, sort of summarize for us, if you would.
Sure.
Go ahead, Lauren.
I'll start. As far as the CHBRP report, I think I said this, they noted there's a lack of data available at the public level. We do know that health plans and insurers do report to the Department of Managed Healthcare in California, Department of Insurance, Division of Insurance. I'm getting all my acronyms and names mixed up. And that we did speak to those agencies, and they also noted even the data they get really doesn't provide a complete picture of what prior authorization looks like for California. There are some reports that are generated by these agencies. Some of them include penalties that health plans have had to, usually they're fines that health plans have had to pay, because they did something incorrectly with prior authorization. I know I'm not explaining that correctly. There's a pretty big lack of data. the federal rule is looking for annual payers to post annually on their websites. And it is more aggregated data on, percentage of approvals, percentage of denials, approvals after appeal, time to decision. So, and these are based on different items and services. But, something we talked about in our project with our stakeholders is that, this information is a great start, but, we could really understand a little bit more if this data was disaggregated. So when we've got larger health service areas, such as, behavioral and mental health, if we just have general, approval, denial percentages, statistics of that nature, it's really not going to tell us which types of behavioral and mental health care, are maybe where there are tons of denials or tons of approvals, and maybe we don't need prior authorization in those areas anymore. So
just two things, Lauren. Just one thing to mention is the information that you just detailed is only available on individual payer websites, and much of the information that is reported to the state is not available publicly. So that's a limitation. And the other thing, just because the disaggregated nature, which was a big focus of our group's work, please look at the new proposed federal rule. The comment period ends on January 27th. It is really worth looking at because they dive into the disaggregation of data, which is a new focus, and I think would be of tremendous benefit. Sorry to interrupt you.
Yeah, no, and Wendy, I don't know, did you note this earlier? That new CMS proposed rule came out yesterday, and that's for Medicare Advantage plans. Okay.
Yes, that's right.
Yeah.
Super, super helpful. Thank you. There's more to dig into there, but for just the volume of questions here, I do want to move us on and kind of go into automation a little bit, and maybe start with maybe a higher level conceptual question. It's a theme that's in a few of these questions here that have come into the chat, and it's around maybe the proprietary nature of medical necessity criteria, and I don't know, maybe the difficulty in moving towards either at minimum, or like maybe standardization at maximum, and like at minimum transparency. That's a difficult thing to do for payers, and is certainly a change from what we have right now. Can you talk a little bit about like the prospects, or what payers are being asked to give up here? That, I think from their perspective, this is the determination of those decisions are made using proprietary criteria. Is that a burden we can overcome, or how do you address that?
So. I think when we've talked with folks, and we've done similar work in Massachusetts, and I think we've received similar feedback. A lot of folks at the base of things use, criteria by interqual or MCG. So there's a lot of commonality in those medical necessity criteria. There's also, you mentioned payers will have kind of proprietary, they have their own kind of twist on things. And they are being asked to codify those rules, which is a big lift to be able to automate. I don't know that I can really speak to what they're giving up. I mean, by codifying this and what they already have, it's not that that's going to automatically result in an approval, even if they don't get the information that satisfies that request. So it's a big lift, and I know that this CMS final rule and what we're recommending is focused on payers. I saw some questions in the chat that are, how do we ensure providers are ready to participate? But essentially, the piece on codifying, medical necessity criteria and payers rules, I mean, there are a lot of automation tools and platforms out there, and health technology vendors, that this is part of the implementation process. So they're not necessarily telling, payer A, go do that yourself, we'll reconvene and connect our system. I mean, that's a collaborative process that they can do together. So, I think... Go ahead, Wendy.
Sorry, the FHIR standard doesn't require every payer to implement the same medical necessity criteria. I just wanted to make that clear.
And
the
Wendy,
FHIR standard is a way of standardizing
I'm really sorry
data.
I'm really sorry to interrupt, but it did come in like that. Can you just define FHIR for all of us, just so we're all on the same page?
Fast healthcare interoperability
Resource.
resources, right?
And can you just let folks know, like, just high level, what is that and what are we asking, who has to do what?
Yeah. So FHIR APIs, it's I think essentially, and I am not like on the tech side of this, I am learning for sure, but that is like a definition of like how to share data. So it's this open standards based way to share information between organizations. So, that's what CMS has put their weight behind. There's the Da Vinci project who has developed these implementation guides that are tested and proven. So that's what we're using.
And so then, sorry, Wendy, for that, but thank you, Lauren, and then sorry, Wendy. So using FHIR can help address some of the technical challenge of being more transparent with medical necessity criteria. I think that's where you're going.
Well, so the FHIR standards are, as Lauren said, to enable us a consistent way for payers and providers to share information. The medical necessity criteria, which we wish would be more standardized, but as Lauren mentioned, there is a significant amount of standardization through the payers' use of these published standards now. But the medical necessity criteria will have to be codified. And then in the process, this is sort of what they call the decision part of the process, the PAS. The rule will deter the payer's rule pulls information using FHIR-based standards from the provider's medical record and can then determine whether the patient meets the medical necessity criteria. The real advantage there of automation is many denials of prior authorization requests are due to insufficient or incorrect documentation. Automation can overcome that in a huge number of cases because the rule that the payer implements identifies what portion of the electronic record it must access to pull that information across to the payer. It's complicated.
It is complicated. I think maybe staying at a high level before we get into some of the technical parts of this is just, we talked about what payers are being asked to give up here, which is being more transparent and potentially standardizing. And there have been a couple questions in the chat, and you both have alluded to what providers are being asked to do here, which may potentially be uncomfortable. I believe it came up, but correct me if I'm wrong. And I would imagine if I'm a provider, I might not want to give a health plan access kind of free reign to my medical records. How have other states approached this, or have they, or has the industry approached this? Like, are there success? Is this a barrier? Are people willing to do this? And how would we approach it?
Yeah. Before I answer that, I do want to also go back as far as like transparency into medical necessity criteria. California has a law. Payers have to share their medical necessity criteria when requested by providers. But if that's automated, that's like a background process. That's not taking administrative time and burden for payers and providers to get that information shared. So I would see that as like a benefit to automation. So as far as payers having access to providers' EMRs or practice systems, whatever they're using, that certainly came up. Providers were concerned about payers being able to, as they said, sift through the EMR. And at the risk of getting technical, this was one of the modifications you can make to the Da Vinci implementation guide. So you can require the use of prefetch tokens and prefetch templates. And so folks were more a fan of the templates because that would allow payers to access the information that is just to satisfy the request at hand. So they can't go looking for other information. The tokens would provide, payers access to more information around, a specific instance. So, or around, it could be data around a particular patient or data around a particular encounter. So the template places more constraints, and just that information is just to satisfy, whatever questionnaire, whatever they need. to satisfy or to process the request. And that seemed to quell the anxiety from providers we discussed this with, and they seemed more open to that idea. And they didn't, say, well, we're not going to do it. So.
Can you talk a little bit about, while we're sort of on the subject of like some of the feedback from providers and provider groups? There was a question in the chat both about costs to this, cost to providers, particularly for smaller provider practices, like how might, or have those costs been offset in, in somewhere else, in other parts of the country, or how might we do that here in California?
Mhm.
And then similarly, what sort of safety tools or anything, or like oversight of a more automated process, have others considered, or might California consider? Because we could see this going, the wrong way, a dramatic increase in denials or malfunctions, glitches, like those sorts of things. We had some questions there.
Mhm.
Do you care to comment or have any thoughts on either of those things?
Sure. So as far as costs, to providers, even to payers, from what I think Wendy and I have read, folks who have already tested this, piloted this, maybe at a smaller scale, but they're all, reporting that they're seeing like a 150% to 400% increase in ROI. So the other thing too is, a lot of the solutions out there to automate are really able to meet payers and providers where they're at. So it's not just a one size fits all and everyone is required to invest 4 million into this solution or whatever. That was just an arbitrary number. But there are also other solutions out there. I'll give an example. So my new organization, the Mass Health Data Consortium, is part of the New England Healthcare Exchange Network, and they have developed an open standards-based collaborative platform for sharing clinical and administrative data, and they're automating both prior authorization and quality measures. And, their pricing is much less than, what others are on the market. And this is, a way for a single point for both payers and providers in Massachusetts. They have this one connection into this network, and they can talk to, or I say talk, but they can automate prior auth, they can share quality data with anyone else who's hooked up to that system. So there are certainly more cost-effective solutions and platforms that are being launched, that are in development. Wendy, anything else you wanted to add to that before we move to the second part?
No, I think most of the cost is going to be borne by the payers in this, but the return, as Lauren mentioned, there will be a return on investment, both in decreasing the friction between payers and providers, but ultimately in saving payers as well as providers significant funding. In our original report on automating prior authorization in Massachusetts, we did propose sort of a loan program for some of the smaller providers in terms of working with their electronic medical records vendors. But I think that the pressure from payers, as well as from the federal rule and legislation, will force electronic vendors to make FHIR-based standards available to providers. We have not heard that that is going to be a barrier for providers making use of these automated processes.
Can you then speak to that's super helpful. Can you speak to maybe the second half of that question, maybe concerns around like what guardrails are in place in a more automated process so that we don't end up with a whole bunch of automated denials, or what happens? There's a question in the Q&A about data breaches and liability. Like, what do we need to think about, or what have other states thought about when it comes to new guardrails that need to be put in place in a more automated world, or with a more automated system?
Yeah, well, I mean, I think tools and platforms that are in existence and are developed, ensuring, security and that they're meeting HIPAA standards and other standards that are required. That's part of the building process. And I can't speak much further into the, security portion and the technical portion on how that is done. But I would also say, in terms of if we're seeing an increase in denials, which is not the goal of automation, I mean, that's where data would come in, and that's going to show us we're seeing a lot more denials in this area. We need to dig into this and fix this.
There's a question that came in, and Wendy, I think you alluded to this in your opening comments around artificial intelligence. And I may be staying at a slightly higher level here. Can either one of you speak a little bit more directly to like when it specifically comes to artificial intelligence, like what is in your view, what is the highest potential for that in the automation context or the data context? And are there any concerns that you have about the use of artificial intelligence in a more automated or less automated process around prior authorization?
Yeah, I think, what CMS has highlighted as a concern, and is certainly a concern across patient groups, is whether AI will generate inequitable care by using biased algorithms. And that's a general concern about AI, which also applies to prior authorization. And in fact, this recent CMS proposed rule really talks a good deal about that. The balance being the reporting of how AI is used, what standards are implemented through AI, and really just clarifying what decisions have been made based on AI algorithms. So if you clarify that and you see a higher rate of denials, then you would be able to flag improper use of AI, or at least question whether the use of AI is appropriate. We think that a lot of these reforms need to be evaluated, but they can't be evaluated if there's not appropriate public reporting of the outcomes of the use of the process. So Cohere, another Massachusetts group, Cohere and Humana have implemented AI processes which have apparently accelerated, we're probably at time, accelerated decisions based on clear standards from professional societies in like orthopedics.
Super helpful. We are kind of coming to the end of our time, so I'm going to need to bring us to a close with one last question on, Wendy, maybe to your point about the need for outcomes or more data, or it would be very helpful to have more data to understand how these processes are being used and carried out and what the results are in the state. And you spoke to, and Lauren spoke to, what some of those sources are. You spoke about some of the data that we don't have. Is there anything either of you might leave our audience with around just reporting burden is often something that comes up, and you spoke to this a little bit, but just reinforcing the point, more data is always helpful in order to understand something, and more data often, almost always, introduces a new burden.
Mm-hmm.
Are there ways in which, or can you kind of remind folks the ways in which, if we wanted additional data on these processes, we might do that in a way that minimizes the burden on any particular part of our system? Any thoughts or any closing thoughts there?
So, again, ideally, being able to pursue automation at the same time will serve to decrease that reporting burden in a couple ways. There's by automating the prior auth process, that's going to provide more access to discrete data or, quantitative data, rather than having to manually sift through clinical notes or other written notes about a particular patient or encounter. The reporting requirements that are also required at federal and state levels can be and are built into automation tools and platforms. So that becomes part of the process and not an added step of now collecting, collating, generating reports. And again, going back to new organization, MHDC, their service, because that's a centralized service that's working to centralize the flow of data and helps to standardize it, because it's one system that they've put in the requirements for reporting, and it's one access point for payers and providers to generate reports. So
And Christoph, this actually gets back to your original question, what is the role of states? So states can do a great deal to reduce the disparity in reporting requirements between the federal reporting requirements that impact public payers and other reporting requirements implemented at the state level that, you know, are out of sync with those federal requirements. Now, we don't, you know, there may be specifics that the states want to address, but the coordinating reporting requirements across all payers, public and commercial, and employers are are going to have to adopt them on their own, would significantly reduce the burdens.
Super helpful. Unfortunately, I think our time, you know, there's a lot there that I could talk to you guys all afternoon, but we've kind of run out of our time for today. And so we need to bring this particular conversation to a close. In doing that, I want to thank you, Wendy and Lauren, for your time today and all the great work that you've done over the last several months now with a really impressive multi-stakeholder group here in California. The results of that work, just to remind our audience, are available in reports that are on both the CHCF and the NEHI websites. They go into much greater depth than we were able to go into today about any of these issues. And I would just say for folks that have joined us today, this is the continuation of a conversation that we hope to continue to have with you in the coming weeks and months. So thank you. Thank you to Wendy and Lauren. Thank you to our audience for joining and participating. A recording of this will be available on our website. All the material will be available there in the next couple of days. And then finally, the last thing is I will just remind you and sort of close with, please do fill out that evaluation form that'll pop up on your screen. We really appreciate the feedback and we'll use it, I promise, as we think about future programming. So with that, I'm going to declare victory and we're going to conclude. Thank you, everyone. Enjoy the rest of your day and we'll see you next time.
Thank you, Christoph. Thank you.
Bye-bye.